Hello, and welcome to Xtalks Spotlight, illuminating insights from subject matter experts and industry thought leaders. I'm Sonia Hunt. In this episode, we are asking the question, how are blood-based biomarkers reshaping Alzheimer's disease therapy? With more, here's Aisha Rashid.
Thank you so much, Sonia. The escalating global challenge of Alzheimer's disease demands new approaches to detection, diagnosis, and treatment. In this Spotlight feature, discover how blood-based biomarkers are reshaping Alzheimer's disease therapy. This includes simplifying diagnosis by uncovering the non-invasive procedures that are making early detection more accessible, promoting early intervention with blood-based tests that enable proactive measures even before symptoms appear, facilitating longitudinal monitoring by learning how continuous tracking of disease progression can pave the way for personalized therapeutic strategies, and boosting cost effectiveness by finding out how this accessible approach is more economically viable, promoting widespread adoption. To discuss recent advancements in the Alzheimer's diagnostic landscape, we are delighted to have Dr. Michael Racke with us for this Spotlight feature. Dr. Racke is Medical Director of Neurology at Quest Diagnostics. His prior research was on the pathogenesis of multiple sclerosis, with early research and preclinical work leading to novel treatments, including anti-CD20 monoclonal antibody treatment for progressive MS. Dr. Racke's training includes an MD from the University of Medicine and Dentistry of New Jersey, neurology training at Emory University, and a neuroimmunology fellowship at the National Institutes of Health. He has served on the faculties of Washington University, University of Texas Southwestern Medical Center, and the Ohio State University School of Medicine. Dr. Racke has been on many advisory committees and boards and has also served on several editorial boards, including JAMA Neurology and Annals of Neurology, as well as editor-in-chief of the Journal of Neuroimmunology. Dr. Racke, I'd like to start off by asking you, could you explain the significance of blood-based biomarkers in the diagnosis and treatment of Alzheimer's disease? And how does Quest's AD detect amyloid beta 42/40 ratio improve upon the traditional approach to AD diagnosis?
So let's start by saying that it used to be that Alzheimer's disease was a pathologic diagnosis. So there would be people who would have memory problems and then later cognitive dysfunction, who, when they passed away, had an autopsy. And then on autopsy, one was able to see the amyloid plaque and the neurofibrillary tangles, the characteristics or hallmarks of Alzheimer's disease. It was probably close to 20 years ago when one of the major breakthroughs was the identification of amyloid PET scans, which were able to demonstrate that in a living patient, we could see the amyloid plaque. Subsequently, tracers were also discovered that could bind to the neurofibrillary tangles, the phosphorylated tau in the neurofibrillary tangle. And so then one had what was known as a tau PET scan. And so one began to have imaging that was able to identify Alzheimer's disease in living patients. Subsequently, one was able to identify changes in amyloid and tau in the spinal fluid that were characteristic of Alzheimer's disease. But to get spinal fluid, you have to do what's called a lumbar puncture. You have to stick a needle typically in the back of a patient, and often has to be done under what's called fluoroscopy, and it's not a very pleasant procedure. Now you can imagine that there was a significant technologic breakthrough to be able to then identify the amyloid and tau changes that one saw in the spinal fluid in the blood. That technological breakthrough was basically because, if you think about it, it was probably the amount in the blood was a log lower than in the spinal fluid, and there are many more competing proteins in the blood. And so it was quite difficult. But now, having been able to do those things, one now has a way that's much easier for the patient because it's a blood draw as opposed to either undergoing the PET scan or the lumbar puncture. And it's also much more cost effective. The other advantage, as you noted, is that it's unusual to do more than perhaps 2 PET scans in a patient's lifetime. Patients don't like to do lumbar punctures. To get somebody to do multiple lumbar punctures would be quite difficult. But to do, say, every 6 months or a yearly blood draw would not be much of a burden on a patient at all. So all those things have made the ability to do monitoring of these markers much easier, much more cost effectively than what was previous.
And so, what has been Quest Advanced Neurology's role in Alzheimer's and dementia research and testing? Could you give us an overview of your portfolio in AD diagnosis and how it's addressing some of the existing challenges in early detection and intervention?
So, we have been involved in AD testing, particularly with spinal fluid, for over a decade. We are able to measure the beta amyloid in the spinal fluid as well as the phosphorylated tau. In our ADMARK testing, it's specifically p-tau 181. And one can then look at some of the neurodegenerative markers such as total tau. And so one can then have an algorithm of those markers to look at whether a patient has the characteristics of Alzheimer's disease or other dementias for that matter. The blood, what is, I think, been the biggest advance is it turns out that if you, the beta amyloid hypothesis for Alzheimer's disease is that for some reason you begin to put amyloid in the brain, and that probably occurs decades before you become symptomatic for Alzheimer's disease. Somewhere, those amyloid plaques begin to cause some toxicity to neurons that results in the subsequent neurofibrillary tangles. And it's those combination that results in neuronal loss and neurodegeneration. And it's those loss of neurons as that adds up over time that one then has the clinical manifestations of Alzheimer's disease. I would say that Quest's role has been in multiple forms. I would say that our AD Detect and ApoE combination testing in the blood allows one to identify people who are at risk, perhaps for Alzheimer's disease. We are participating in studies like the AlzMatch study, where one identifies people who are cognitively normal, but already seem to have some of the characteristics of early changes in Alzheimer's disease to see whether treatment in those early stages might be beneficial. I should point out that over the 20 or so years that clinical trials have been done, that early on, the antibodies weren't necessarily as good as they are now for the treatment of Alzheimer's disease. But the other thing was that we weren't as good at identifying patients. So in the early Alzheimer's disease trials, up to as much as a third of the patients actually didn't have Alzheimer's disease. And so you can imagine if you have a treatment for Alzheimer's disease, but you don't really have it, you have some other form of dementia, that's not likely that's going to be successful. Recently, there have been now several successful clinical trials, and one of the important factors has been that we are now much better in identifying patients who really have Alzheimer's disease based on those biomarkers.
And so, Dr. Racke, you did mention that there is a silent preclinical phase in Alzheimer's disease, so to say. And so this is where changes occur before symptoms appear. And I'd like to ask, how does your work, specifically in developing blood-based tests like AD Detect amyloid beta 42/40 ratio, really aid in the early detection of AD? And why is this so crucial?
So, I mean, I guess that's a good point. And I guess one of the things I should say is that the field is rapidly changing. There have been diagnostic guidelines put out by the National Institute on Aging and the Alzheimer's Association. And as recently as 2018, it still was suggested that you needed to identify both the changes of amyloid and p-tau in the spinal fluid or by PET scan as a way of diagnosing Alzheimer's disease. In the recent Alzheimer's Association International Congress that was held in Amsterdam this summer, they put out new guidelines that basically, for the first time, suggested you could use plasma-based biomarkers. And they suggested, for example, if you had an abnormal 42/40 ratio in the plasma, that you still needed to have either a plasma test that showed that abnormality for not only amyloid, but p-tau. So again, you had to have both amyloid and p-tau, or you could use CSF and show demonstration by CSF that there were those same changes in amyloid. The other thing that they emphasized was that the clinical picture had to be appropriate along with the biomarkers to make the diagnosis. And so one of the things that I think has become very clear is that there are now many other biomarkers that people are looking for. The p-tau and amyloid clearly are the hallmarks of Alzheimer's disease. But there are now other markers like neurofilament light that are suggestive of neurodegeneration. There are things like glial fibrillary acidic protein, or GFAP, that are a manifestation of gliosis. There are other markers as well that allow one to now more accurately put somebody along what we would say is the Alzheimer's continuum. So that if I tell you that there's a 20 to 25-year preclinical phase, with these other markers, I can more accurately determine where you are along that pathway and how soon it may be that you have clinical symptoms, or if you have clinical symptoms, how much damage has already occurred to the brain.
And so there appear to be obviously a lot of benefits in using blood-based tests, but can you elaborate on the benefits of using these tests for Alzheimer's diagnosis as opposed to traditional methods like MRI, CT, and PET scans, as you've discussed? And how does this approach contribute to patient care, accessibility, and cost effectiveness?
Well, now that gets to be a little more complicated, but let's just say, for example, for somebody who has early signs of cognitive dysfunction, all right, and one gets a blood-based test, and let's say it was AD Detect, and that the ratio is completely normal at 0.180. That actually provides very useful information to the clinician, because it would suggest that the likelihood of that person who's having these early memory problems doesn't have Alzheimer's disease. They have some other underlying dementia or some other problem that is resulting in them having their difficulties with memory. If particularly, I use that example because if you are above a certain cutoff, it is very unlikely that you have amyloidosis. So you would not necessarily have to go on to have either a lumbar puncture or a PET scan. And that's in and of itself could save the healthcare system millions of dollars. Now, the other issue is that, as we mentioned earlier, you can follow this test over time. And as one gets older, one's risk for Alzheimer's disease increases. And in addition, if one could say have a normal amyloid ratio, but if one followed that over time, that could become abnormal. And then, as we mentioned earlier, that could signal to a clinician that you should try to perhaps do lifestyle changes for trying to prevent Alzheimer's disease. One of the things that's very interesting, the World Health Organization has put out a number of recommendations for things that people can do to try to prevent Alzheimer's disease, with the idea that this is something that they're worried about as becoming a public health crisis globally. And obviously, if you have a marker that now suggests you're at risk, then that also allows you to think about monitoring perhaps that person more closely, and then perhaps either getting involved in clinical trials or other things, or other strategies to try to reduce the amyloid burden in your brain.
And so, Dr. Racke, looking to the future, what possibilities do you see for further advancements in blood-based biomarker technology for Alzheimer's, and as well as other neurological diseases? How can pharma partners and other stakeholders collaborate with Quest to drive innovation in this field?
Well, that's a very good question. So one of the things, as I mentioned earlier, is there are other types, there are, first of all, biomarkers for both amyloid and tau. And one is beginning to see that there are different isoforms of tau, like p-tau 231, p-tau 217, p-tau 181, etc. And some of those suggest that they come up even earlier than some of the other p-taus that are allowing people to identify people who have these positive biomarkers. Another thing that's important, and for example, I can use the recent clinical trials in lecanemab and donanemab. Because the treatments target amyloid, a requirement was that you had to have amyloid. But if you think about it, I could have amyloid and I could still be 10 years perhaps away from when I get the clinical manifestations, or I could just be very early in my manifestation. If I had also a positive p-tau, that typically arises much closer to the clinical onset and signifies that the pathologic process is perhaps accelerating. And what people have seen, what people observed, is that in the donanemab study, by making sure that people had both amyloid positivity and p-tau positivity, if you looked at the differences between the treated and untreated groups, there was a bigger difference. In other words, it appeared that the treatment had a greater effect because they did a better job perhaps in selecting patients whose cognitive deterioration was accelerating. And so I think one of the things that is very clear is that by using these different biomarkers, we're becoming very good at, as I said, knowing where you are in the Alzheimer's continuum. The other thing that's, I think, going to be important is that there are other imaging people talk about the fact that the biomarker is positive years before the PET scan is positive. And it looks like, for example, that an MRI is positive or begins to show changes of Alzheimer's disease after the biomarker is positive, but before the PET scan is positive. So we may see different imaging modalities being utilized and different biomarkers to try to identify these people at the earliest stages. And I think one thing that's true in neurologic diseases, not just Alzheimer's disease, but pretty much any neurodegenerative disease, that the earlier you identify when there's been less damage done and then interrupt that pathophysiologic process, you're basically preventing more damage earlier, and so the patients have better clinical outcomes.
Thank you very much for speaking with us today, Dr. Racke. We look forward to learning more about accelerating Alzheimer's therapy innovation through the power of blood-based biomarkers. Thank you all for joining us for this Spotlight feature. We hope you enjoyed the discussion.